Hi, my name is Mattia and I'm the medical professional with a specialization in Tourette's.
My name is Jenna and I'm an intervention specialist. I'm going to be taking you through the methods used in our intervention today.
Tourette's is an inherited neurological condition characterized by variable expressions of unwanted movement and noise, i.e., tics. Simple tics are sudden, brief, and repetitive tics which involve a limited number of muscle groups. Complex tics are distinct, coordinated patterns of movements involving several muscle groups. Tourette's is involved in the functioning of the basal ganglia in the brain. The basal ganglia is responsible for making movements and preventing unwanted movements. Tourette's targets the pathway that prevents unwanted movements. The goal of the pathway to prevent unwanted movements in a normal functioning individual is to increase the activity of the globus pallidus internal in order to decrease the activity of the thalamus. Decreased activity of the globus pallidus external results in less inhibition of the subthalamic nucleus and therefore increased activity. The subthalamic nucleus activates the globus pallidus internal, increasing its activity. This increase in activity results in increased suppression of the thalamus, which means decreased activity of the thalamus and therefore no movement. Broadly, Tourette's is due to an imbalance in the function of the neurotransmitter dopamine. In addition, it is a result of failures in the circuits connecting these basal ganglia regions discussed. The cause of Tourette's is unknown. However, common risk factors and possible theories are currently under study. To start, men are 3 out of 4 times more likely to have Tourette's. The autoimmune theory states that antibodies directed against an antecedent infection cross-react with neuronal structures in the central nervous system. The genetic theory states that Tourette's is related to genetics, and although no specific gene or genes that cause the disorder have been found, this theory is backed up by the fact that a good majority of cases are inherited. Tourette's is found in all ethnicities. 50% of patients will see a reduction in their symptoms after their teenage years. The average age for diagnosis of Tourette's is 6 years old. 85% of Tourette's patients usually have another disorder such as ADHD, anxiety, depression, a learning disability, or obsessive compulsive disorder, to name a few. 1 in every 360 children have Tourette's. However, it's estimated that actually 1 in every 162 children have Tourette's, but most cases go undiagnosed.
We are doing our intervention on patients with Tourette's, specifically with an arm tic. The training regime is a 3-stage process of habit reversal training. Our practice variable being used in our intervention is observation, which is a learning variable. We use observation to teach the patient to counteract the tic motor response using the indirect feed-forward practice technique. The first stage consists of 1-hour sessions twice a week for 2 weeks and is tic description and awareness. In this stage, they meet with the experimenter for an interview where they are filmed. After the filming's done, the patient watches the tape, as studies have shown that by having the patient observe their tics will increase their compliance with the intervention. The second stage is the competing response stage. This stage consists of 2 1-hour sessions a week for 2 weeks. This is where the experimenter or behavioral therapist trains the patient to perform a counter movement to their premonitory response as observed in the videos, rather than their tic. For this, we are going to have our patient hold their arm where they have the tic against the body as tightly as possible for their premonitory experience. Additionally, it is important during this stage to have family for social support to remind the patient to engage in the competing response behavior and praising them when they engage in the behavior. We are going to give their immediate family a chart to fill out where they record the number of tics the patient has, how many times they gave them positive feedback and praised them, as you can see here. The final stage, or stage 3 in our intervention, is the relaxation training stage. Relaxation training in combination with habit reversal, as we know from Woods et al., has been proved to be effective. This training occurs according to the discretion of the therapist. If tics are more severe, then it's offered once a week for 10 weeks. However, if they aren't as severe, then relaxation training occurs only once a week for 6 weeks. In our intervention, our techniques for muscle relaxation are going to be progressive relaxation, which consists of tensing a specified muscle group, in our case the arm, and then relaxing it. The procedure we have for analyzing our data during our intervention consists of a pretest video where we record the number of tics they have before intervention. For the post-test, we record a same-length video and count the amount of tics that happen again, and then we'll run this data through a pair sample t-test and see if the average number of tics is significantly different. From this data, we can graph it to obtain the performance learning curve, as you will see in the graphs to come.
I'm Madison.
And I'm Lindsay.
And we're going over data analysis for our intervention. So I'm responsible for going over the results.
And I'm responsible for going over the discussion. Our results for our intervention are based off results found by Azrin and Peterson. The dependent variable across all figures for our results is number of ticks per hour. As you can see from the scatter plot, there was a learning curve across the 12-month-long intervention. The baseline value for average number of ticks per hour was 180. After just 1 month of HRT, the number of ticks dropped down to 130. At the end of HRT training, ticks were reduced to just 5 ticks per hour. This graph more clearly shows the difference between baseline and end of intervention values. It also puts into account how these values did not deviate too drastically from their respective means, as shown by standard deviation bars. To test if the difference between the baseline and end of intervention values were significantly different, we ran a paired sample t-test. From this test, we determined that the values were significantly different, as p was less than 0.05. However, our intervention doesn't end here. We revisit the client after 3 months to conduct transfer tests. HRT has been shown in multiple studies that it is retained after long periods of time. For our intervention, we would extend this to transfer tests. The purpose of conducting these tests is to see if the client learned HRT, as well as if they can generalize what they learned. In the first test, we would test intra-task transfer. We would meet with them 3 months after the last HRT session in a public setting, for example a coffee shop, as it has been well documented that anxiety increases the rate of tics. We would then record the number of ticks per hour. As it is well known that HRT is retained, we predict that the client will be able to generalize his training as well. In this case, we predict that they will be able to suppress their tics in this new environment. In the second test, we would test for inter-task transfer. Also after 3 months, we would have them perform activities of daily living, such as washing dishes and doing laundry, and we would observe if they are still able to suppress their tics. As mentioned previously, it's known that HRT is retained, as well as Azrin and Nunn reported that people with Tourette's who engage in HRT are still able to suppress their tics while engaging in other behaviors such as exercise. From this, we predict that they will be able to transfer what they learned in HRT to activities of daily living.
The key finding for the intervention is that there were significantly less tics when they came for the retention test 3 months later compared to when they came for the pretest. Tics were reduced in subjects by 97%. Our results corresponded with the other similar studies in this field showing the impacts of habit reversal training on tics. A study was done by Azrin and Peterson investigating the effects of habit reversal training, specifically assessment training and competing response training, which was similar to what we did in our study. They observed the amount of tics in a clinical setting as well as the home setting before, throughout, and after habit reversal training. The results found that both groups that started treatment right away and those waitlisted and starting 4 months later both showed significant reduction in tics, averaging 93% at the 12-month mark after training. In a separate study conducted by Azrin and Nunn, 1 session of habit reversal training was given to subjects with tics as well as nervous habits. All subjects were found to have reduced the nervous tic by 99% 5 months after training. During the follow-up appointments, subjects stated that they were able to suppress tics while engaging in everyday activities, showing that the skills were transferred. This also complies with the results of our study. The awareness training was effective as the practice variable observation was utilized. By showing the subjects videos of themselves, they became more aware of how their tics occurred and when they occurred, which helps them understand their own tics. It has been shown that observation of a novice, which the subject would be as they haven't learned to control their tics yet, would help improve their performance. During the competing response training, the automatic route from the motor cortex to the muscles in the arm is activated during the tic. By increasing attention, the patients begin to override the automatic route of the involuntary tic for the intentional route, which is pushing the arm into their leg when an urge is sensed. This process potentially becomes a natural response due to the altered synapses and mapping of the brain. However, additional studies need to be done to conclude this. These findings of our intervention can connect to many real-world problems. Reducing the number and severity of tics improves the self-perception and physical capability of performing everyday activities. They are able to participate and feel more confident in a social setting, especially a busy one. A study by Rowe, Yoon, and Durr correlates Tourette's syndrome with behavioral and emotional problems, resulting in social, academic, and vocational impairments. Hopefully, with decreasing the frequency of tics, there will be improvements in not only the physical well-being, but emotional well-being and confidence of several areas of these participants' lives.